Good afternoon, colleagues.
Good afternoon, Dr. Dels.
Yeah,
We
I'm
can
glad
hear you.
you can hear me very well.
Yes.
Can
Good
the team from
afternoon.
Good afternoon. Can the team from Nigeria hear me?
Yeah, I can hear you. This is
Okay,
Bertrand. Yeah,
fine. Is it morning or afternoon in Nigeria? What is it?
it's 1 p.m. afternoon.
1 p.m. It's afternoon.
Mm.
So, colleagues, you're welcome to this important webinar where we are presenting, or we are sharing a very important topic: realizing sustainable impact through artificial intelligence-powered diagnostics. Lessons from scaling up digital chest radiography for TB detection in Nigeria. My name is Lukoya Deus. I'm the public health specialist, tuberculosis, Centers for Disease Control and Prevention, Kampala, Uganda. And in summary, this presentation shares KNCV Nigeria, Nigeria's KNCV program piloting and further scaling up artificial intelligence-enabled PDX technology for TB active case finding nationwide. It highlights key lessons in deployment, health systems, integration, strengthening, collaboration, capacity building, and sustainability, with insights for programs aiming to scale digital diagnostic innovations in resource-limited settings. And it's going to be presented by none other than Dr. Dume Bertrand. And about Dr. Dume, he's a public health practitioner with long-standing extensive experience in both government and private health sectors, managing and implementing valid public health programs in Nigeria. He is also an alumnus of the Harvard School of Public Health, the London School of Hygiene and Tropical Medicine, and the John Hopkins School of Public Health. Dr. Bertrand joined KNCV International in November 2019 as a country representative in Nigeria. He transitioned this entity into a local indigenous organization, that is KNCV Nigeria, and became the pioneer executive director in January 2020. He is also the chief of party for the TB loan project, which is funded by USAID, supporting comprehensive TB care and treatment in 14 states in Nigeria. He started his career as a TB program officer with the National TB Stroke Leprosy Program, Federal Ministry of Nigeria, Ministry of Health in Nigeria, before joining the U.S. Centers for Disease Control and Prevention. At the CDC, his work earned him international awards, including the Excellence of Program Delivery and Public Health Protection by the U.S. Directorate of Global Health and at Global TB and HIV. And he has authored over 40 publications in peer-reviewed journals. He's a vice chair of the International Union Against Tuberculosis and Lung Disease, Africa region, a founding member of the Nigeria Stop TB Partnership, and currently the first executive vice chair. He's married and has 3 children, 3 boys. Please join me in welcoming Dr. Dume, who is going to make us this presentation. Over to you, Dr. Bertrand.
Thank you. Thank you. There's okay. Are you sharing the presentation?
I think Damal is going to share.
Okay.
Or one of the 2.
Okay.
All right, just give me a second. Okay, I hope everyone can see my screen.
Not
I
yet.
think it's on the way. And as it comes, I think let us listen carefully and attentively and keep all the questions and comments until the end of the presentation, where we are going to have a very productive discussion.
Or can I share? Can you see my screen? so that I can equally
Yes,
control
yes,
it.
yes. We can now see the screen
Yeah,
from
I'm
where.
sharing, so I will be able to control from my end.
Oh, okay, fine.
Okay. Okay, I hope everyone can see the screen.
Yes, very clear,
Okay.
and we can hear you very
Okay.
well.
Okay, thank you everyone, and I must thank the NTP of Uganda for the opportunity and the Makerere University for us at KNCV Nigeria to be able to share our lessons, introducing and further scaling up portable digital X-ray with artificial intelligence for TB active case finding in Nigeria. This is the topic of the presentation. I must equally thank the CDC, Deus, for anchoring this, and I'm equally sure the other participants and equally some from the National TB program. We did this work together. This will be the outline. I will present some brief overview of who we are as KNCV Nigeria and share some insight in the awareness on wheel, which actually informed the initial inroad into the use of AI in active case finding in Nigeria. I will talk on the scale up of PDX and a summary implementation strategy, and equally share some insight from what we're able to do in Nigeria, the funding for the project, the normative guidance we're able to develop, including the algorithm, how we're able to ensure integration, capacity building, and most importantly, some lessons from what we're able to do from the startup implementation to the scale up. And I will be able to share a summary result from intervention for a given year, starting from January 2025 till December. And we share our insight into some challenges, and I will be able to share pictures from the field. Now, this is who we are as KNCV in Nigeria. KNCV history in Nigeria dates back to 2004 as KNCV Global. They were able to implement circles of funding projects from USID, from TBCTA, TBCAP, TBK1, and Challenge TB. But the movement into a local entity started with even the registration in 2016. But within this period, towards the end of 2019, we were able to be funded by USID under the WAS project that actually helped to steady our team, and the actual transition into a local entity happened. But since coming on board as a local entity, we've implemented or implementing close to 10 projects. Those including are actually the current active projects. Some we've implemented and closed, like the Glovers, the SEAS, the DAS project, TB connectivity, and the TIFA. But currently, we're implementing the TB loan in 14 states, the Global Fund TBPM in about 7 states. The GF Impact Project is a countrywide project being implemented, and we are leading that implementation, working with the NTP, with funding from Global Fund, and the NTBSCP, the ongoing DRS, which we are working with the National TB program. And recently, we are actually introducing some new diagnostic tools under the Gates Foundation, the tool evaluation, the two project that's actually going to be piloted in Kano and Anambra State. Now, with the ongoing project I've listed, currently we have our footprints across all the 36 states and the FCT across the ongoing 5 projects, as you could see in the Nigerian map showing all the states and the project distribution. Now, I say that in that introduction, it must be known that we wouldn't be able to be where we are without the successes. The KNCV, even before we came as a local organization, it introduced the awareness on wheel, and you could see in that picture is a mobile diagnostic tool. It came into being in 2017 under the Challenge TB project with support from Global Fund. With support from USID. Yeah, it's actually an integrated system having a digital X-ray in one compartment with AI and the 2 gene expert, 8 modular gene expert in the other compartment. And it's designed for mobile TB case finding in hotspots and hard to reach community. And what we've noticed that beyond testing for TB, it was seen as an excellent advocacy tool. Once he moves into a community, it comes with a wow effect. Even when he had left the community, we've seen increased uptake of services, and they had equally served as excellent advocates because in 2 states in Nigeria, we were able to get the buy-in from the state government in Kaduna and in Lagos State, of which they have procured their own wellness on wheel with our technical assistance. They have operationalized it, and we've seen increasing number of TB cases coming from that intervention. Now, the portable digital X-ray in Nigeria, as you are going to know, we've moved from only one PDX. That was in the late 2019, 2020 to over about 370 currently. But that story, we can't tell it without mentioning the very first pilot, of which we reached out to DEFT. They were able to loan a portable digital X-ray to us, and we commenced the pilot implementation in 2 states of Akwa Ibom and Cross River. And the result was very phenomenal. I must tell you, looking at the results, we even shared an interim results in the Union Conference with a number needed to test of 3 and number needed to screen of 4. And that was actually the very first and the most efficient intervention we've been able to demonstrate. And that success, we disseminated it nationally and globally through webinars, and equally published it in the public health action, the use of portable digital X-ray for TB pre-diagnostic screening in rural communities in Nigeria. It was actually well received, and I must give it to this pilot that opened up the scope for the scale-up that I'm going to discuss further. Now, working with the awareness on wheel, the combined successes from had led to other innovations with USAID funding opportunity, like the introduction of the awareness on keke. The awareness on keke innovation is a local solution. It's a rickshaw assembled here in Nigeria by a local car manufacturing company. It's aimed at reducing the cost. We've seen increasing cost of the awareness on wheel, and since it's smaller, requires less resources to achieve comparable results. In the awareness on keke, we have is manned by 2 people. One is the laboratorian, one could be a radiography technician or radiographer, and one of them is repurposed to even be the driver of the awareness on keke. It can actually move further down to very hard to reach locations. It has those comparable tools. It comes with portable digital X-ray and another molecular tools. It could be TrueNAT or TB lamp that takes it to the very hard to reach communities. They mount there, do the screening, and the diagnosis are actually made on the support or on the spot. The concept of the work was actually informed by the need to address some of the challenges we've seen working with the awareness on wheels. And we've actually demonstrated a very good result to work, and it was introduced during the COVID with funding from USAID. Now, scaling up chest X-ray with AI, and following the successes and lessons we've learned from the pilot, USAID funded the procurement of additional 10 units as an initial scale-up to be deployed to hard-to-reach communities and special population, especially the prisons, the internal displaced people's camp, refugee camps across 9 states. The successes of this initial uptake informed further introduction of PDS with AI within HIV settings in one of the projects we had on the HIV with another local implementing partners in Lagos and Bayelsa. And the result from this project had actually opened up the scope and the space for the HIV program. And currently, all the HIV implementing partners in Nigeria have ranging to, I think collectively they have over 50 of the portable GCs. They're using it to target active case finding within the HIV settings. And then the real game changer was through the funding from Global Fund, the G7, that later took this project to a full nationwide scale by procuring 370 units of the PDX across various partner manufacturers from the DEF, the Mini X-ray, and the Fuji. And currently, working with the national program, we've been able to introduce and scale up this portable digital X-ray across all the states in Nigeria, including the Federal Capital Territory. We started with community expansion, then we started the facility. Now, looking at what we've been able to do, we've been able to articulate this strategic framework just to showcase the steps we've taken from the pilot to the scale across the states in Nigeria. We label this first, you need to plan, you deploy, but most importantly, Most importantly, it must ensure sustainability. First is to define the objective and scope. For the national program, they were very, very clear. They know the gap in program intervention. Most of us missing cases are in the community. And rather than wait for the clients to come to the facility, we needed an intervention that would be able to take the services to where the patients are. And one of those was actually very handy with portable displays. We were very able to clarify our targets and the priority populations because looking at the cost and the manpower, we need to be targeted. And within our program, we have our hotspot analytics that help us to be able to profile the areas that we need to target, where they are most burdened and where most cases are coming. Now, following this, there was needs assessment and mapping. Where are these locations? I must tell you that we've been able to comb most of the prisons in the country, and KNCV only got some recognition from the prison services because these are very most at-risk population. The IDP camp, all those were mapped across the states, and we had a very targeted intervention. Number 3 here is governance and coordination. And we cannot talk about our successes with PDS implementation without mentioning the national TV program. The collaboration had been very, very phenomenal. We worked with them, even they made that recommendation to Global Fund that we should lead the impact project that had ensured the skill across the country. We start with them, developed most of the normative guidance, the SOPs, learning from our experience doing the initial pilot and the other scale-up working under the USID grants. And the service delivery models, these are based on our experience. You will see they are facility-based, where these tools are deployed to the facilities, and they provide services for clients for TB screening and mobile outreaches, where we were able to introduce the awareness on KK that could couple the PDS with a molecular diagnostic tool moving to very hard to reach locations. And equally the need to have the hub and spoke mapping, where that will facilitate even sample referral when the molecular diagnostic tools are not in the field, and equally linkage for treatment. Site preparation for facility-based intervention, power, security of the tools, and mapping out facilities, ensuring transport and sputum referral, IPC, and equally making sure you have the manpower and the space readiness. And workforce training have been very key. Normally, we have a cascaded training where we have a central team, the training of trainers. People have been trained both across the KNCV, other implementing partners, and national program. And this team work with the product manufacturing in the system activation. They do on-the-spot training, and even at the deployments, the team actually move from the training with their tools to their states and then move to the facility. And we continue this training by on-the-site training, capacity building, even through some webinars and even competency-based training that we've introduced. Now, referral and testing pathways, I must tell you, is only a few of these digital tools that we have it coupled with the awareness and where you could have the molecular testing happening on the spot. And naturally, you need to map the community locations, the referral site, treatment site, to ensure there are no mixed opportunities. And data systems is equally very key. And a good thing that the national program has to introduce the ComTV, that we have real-time collection of this data from the facilities. And one of the game changers, as I'm going to show on a slide, is the SMAP, where we'll be able to introduce a dashboard. It is actually a digital reporting platform that had ensured optimization of clinical diagnosis. The digital films are uploaded right there in the field and sent to the cloud, and engaged radiologists, some of them are not even in the country, could get the result and make the report and send it back through the cloud system directly to the peripheral sites where they're being referred by the radiologists. This had helped to actually bridge the turnaround time and optimization of our clinical diagnosis. Another key model is maintenance and uptime. We had issues at the initial time, turnaround times, spare parts replacement, but I must commend the product manufacturer, Deft, and other product manufacturers that they had built local capacities, and they have in-country representative that we could come and within a short time, they will be very responsive. Where there are needs to change parts, some of them happen within 24 hours. And another important point here is community engagement. Demand creation is very, very key. Even in facility deployment, we ensure that awareness are created among the clinicians. And even in the community, there's community mapping, the stakeholders engagement, and we had worked well working with community-based organization under the Global Fund. But the last but not the least is that we've been able to keep track of our key performance indicators. I'm going to show you the cascade we've been able to keep track since the start of the project, measuring our key performance indicators. And luckily within the project, both the TB Loan and Impact project, we've defined our key targets, of which I must commend the team that we've been up and doing, addressing some of the responsibilities as the implementer. Now, these are some of the, coming down to collaborations, we've worked with the states, they are very, very key. The implementing partners, not only KNCV, the other partners will work under the Global Fund, depending on the state allocations for the partners. The community-based organization have been very key in driving the community intervention. The picture you can see there is some of our interventions in the state. One is with one of the governors in the Benue, one of the states in Nigeria, and one is in IDP camp where we deploy the wild truck. And at the initial time, advocacy to nuclear regulatory authorities is equally very key because they need to equally give approval. So we have done increasing interventions in prisons, immigration services, and working with them early in the planning had been very key. And collaboration and task sharing with other implementing partners, we must equally commend IHVN being the prime. We've been able to leverage the support from other implementing partners under the CPPM to drive our community active case finding by providing logistics support and funding for community engagements. Traditional rulers, religious leaders, and even philanthropists had actually provided support in supporting our active case finding within the communities. Now, for health system and insurance sustainability, something that's worth learning here is what national program actually worked out with the Global Fund. Because when we looked at the tools, 370, the cost of HR, I'm not even talking the cost of procurement, was actually seen to be very huge. But the NTP were able to work out, we all sat together, how could this be done? And that 50-50 sharing, where the Global Fund is funding the community intervention, providing support for operationalization, the human resources, and the national program in their wisdom, working with the state where the 50% of those PDS going to every state actually domiciled in selected secondary healthcare facilities under the ownership of the state government, where they are actually responsible for the salaries. And one good thing we're able to come out even in the MOU with the facilities that for every client coming for chest X-ray will be free. But you should know that the PDS can equally provide estate services for other body parts. In the case of intestinal obstruction, fracture, and they could generate some funding that could ensure sustainability and equally sources of resources for even maintenance and even the stipends to the engaged staff within the facilities. Now, we've ensured training, I've said earlier, working with the local partners, representing those tools, and with virtual refresher training, on the job training. And in some of this training, the good thing that before we've actually come up with the national guideline for PDS implementation. It's like a Bible, has all clear responsibility and all the tools, and we're equally calling the local partner that is responsible for the digital mapping, the XMAP, and is equally embedded in the training, troubleshooting, radiation safety is actually a whole component on itself, and we continue ongoing monitoring visit. And the team, our team are currently in the field. We identify and what actually informs some of our targeted visits as we monitor these results real time across all the states. We know where there are gaps, and our team here working with the state program and national TB program ensure that hands-on mentorship are actually provided. Now, responsibility for the NTP, all these are well defined in the guidelines. The NTP, the principal recipient for the PDS implementation, they provide overall project coordination, advocacy, engagement with the state government. Actually, our front when we have issues with the states, and they have been very, very commendable in the support we've gotten from NTP, the development of guidelines and SOPs, working with other partners, WHO, we've been able to come up with very key documents for the PDS implementation, which are actually very, very key. With monitoring and supervision of project implementation, we work hand in hand with NTP and the state team to ensure this, and providing oversight to even KNCV project implementation. They equally manage the grant because they are the prime recipients of the funding for the impact project. Now, the funding mechanism, I must say it because the initial funding for the project came from the KNCV through the loan when they loaned us the PDS. Following the successful result, it was eventually gifted to KNCV, and we equally got another donation for mini X-ray. And subsequently, the results coming from this ensure the upscale with funding from USAID and Stop TB partnership with 10 PDS. But the funding for the grand scale up came from the Global Fund, with the 50% for implementation funding for the 370 actually coming from the government of Nigeria, because in those sites, they take responsibility of the HR support. Government is responsible for providing health facilities and personnel for the 50% of the PDS deployed on the facilities. So we've actually leveraged some support from individual philanthropists and even religious organizations in the community outreaches across the states. Now, I've talked about the XMAP. This is actually a very key game changer, and it is something that any country or any partner interested in PDS would need to look into. Some of the innovations we've done in KNCV are actually based on our program implementation experience. When we notice some gaps, we brainstorm and see how we'll be able to be innovative in addressing some of those gaps. When we started the Wild Truck, one of the key gaps we noticed is tracking of the results. We are sending results then through email services to the radiologists. 5 could be sent today, tomorrow 5. At the end of the day, got 3. Nobody keeps track of the results, no quality assurance mechanism. Not until we worked with a local partner to develop the SMAP dashboard. This actually ensures is an automated process for digital X-ray reporting. It had ensured drastic reduction in turnaround time for digital X-ray. And most importantly, it helps us to optimize clinical TB diagnosis. When you look at the community result, you will see that most of the cases would have been missed if not that we're able to optimize clinical diagnosis. And working with the local partner, we're able to have an inbuilt quality assurance system to actually ensure that any clinical diagnosed case is actually a case of TB. And they had ensured accurate tracking of reports. If you look at this, we have about over 84,000 requests, and the total reports by the radiologists stood at 83,000. For every request, we keep track of the report, and they are all in the system. And seamless and very easy to use, and we equally introduce the e-presumptive register. If you see, looking at the dashboard, you see the daily results. Every day, the total suggestive, total that are not suggestive, and even monthly summary. The graph here, what you could see here is a result, because we have dashboard for each given project. This is a dashboard coming from the TB loan. It showcases the results, the requests, those reported, and in red are those that came out as presumptive. If you look at the trend line here, you could see drop down in the month of February and March. This is actually where we had, in February, actually where we had the project termination. But luckily for KNCV Nigeria, the termination was eventually lifted, and you could see the results started going up over the months. Now, working and based on our experience, we work with national program on other partners to develop most of the normative guidance. So this is actually the screening flow. What happens when we move either to the facilities or in the community? I'm going to share some of the algorithm. The first is registration, and at that registration desk, the symptomatic screening, the WHO 4 symptom screening happen. What you will see here is a parallel algorithm. Everybody is screened symptomatically. They passes through the X-ray with AI, then in the Wild Truck or even the portable digital X-ray. And based on the result from the X-ray, we've actually, over time, come up with cutoff, or which varies depending on the location. For a CAT4 TB greater than 40, this actually seen as a case of presumptive. And for a presumptive, if you have sputum collection, they goes for molecular diagnosis. And for those that are less than 40, these are non-presumptive cases. But when they have cough, they can equally produce sputum to go for molecular diagnosis. But when there is no cough, they can exit. And depending on the outcome of molecular diagnosis, it could be MTB detected or MTB not detected. And the referral will occur as appropriate. And for MTB detected, since the national program had prioritized the use of these molecular diagnostic tools, we were able to know whether it's RIF detected or not RIF detected. But in case where it's a gene expert, every positive case actually sent for RIF resistant testing. And depending on the outcome, patients can now be linked for treatment, either in the community or in the facilities as the case may be. Now, based on our experience, we've been able to come up with a cutoff. We have a very large source of data. I will tell you that this cutoff had actually reduced over time. And I must equally commend USAID then during the Neutral project, a very extensive research actually was conducted where we were able to calibrate and agreed on cutoff for when screening is coming in a community or where it's coming in key vulnerable population, or even in high volume facilities or in low volume facilities. As you could see here, this is actually screening in a community or in key vulnerable population, be it in prisons, in IDP camp, or people in detention camps. All clients first have the 4 symptom screening. They will equally pass for a screening with chest X-ray and AI. And depending on combination of the two, it will have those that are presumptive for TB and those that are non-presumptive. You will exit those that are presumptive will flow down the line. And patient with CAD in community will set it at 40 and above, but in key vulnerable population is 34. But if you are using QAI, which equally another AI tools is 0.4 or 0.34, depending. And we've come with this algorithm defining what should happen in low volume facilities, what should happen in high volume facilities, and what should happen even in a key affected population. And in our training, these are very key tools during our training, and all these are actually annexes in the implementation guidelines. Now, I must talk on the key lessons. These are key takeaway from this presentation. I will continue to thank the National TB Program. Working with them had made this work so seamless, and we're able to demonstrate most of these results. For any country interested in PDS, even if it's a partner, I think if you really want success, you must work well with the national system. We, at the initial time, held a webinar, well received, and in the webinar, the USAID team, the National TB Program, were able to showcase that initial result. It helped to working the awareness and even the collaboration that we needed from key stakeholders, even clinicians across the state. Now, I must tell you that we as KNCV, having technical staff with foreknowledge of even the wild truck that have been introduced since 2027 and the pilot DLB, we're able to have the technical know-how working with the national program to develop most of the guidance, and they equally provided support in the scale-up. I had talked on the XMAP for real-time reporting of X-ray report. This is actually very key, and keeping track of the results. And one good thing that it has an inbuilt quality assurance system. At the time, we felt there were over diagnoses, but looking at the quality assurance system we put in place, so we could beat our chest that we are actually getting the results from the field. Engage staff with some basic IT skills. These have been very key challenges we've seen in the facility deployment, because IT skills basic, and these guys must have at least an Android phone to be able to operate and even upload using the laptop. It had been a very key challenge, and I think having this basic skill will be key in engagement of staff. Government staff for government support for facility-based intervention is actually one of the major gains, where government has taken ownership of facility-based intervention. People coming for chest X-ray that are provided for free, but when you are coming for X-ray for other body parts, they pay some stipends. It had ensured ownership and sustainability, where Global Fund is providing support for the community-based intervention. Now, another key takeaway here is engagement of local support technical team. We started with MapPage on that depth, and now other partners in country had learned because they have this local team that are they have the spare parts, they have the technical know-how. Initially, when we were running to Ghana or there looking for spare parts, the turnaround time, but now a call any of the local partners, they will be there to provide the support that you needed within 24 hours. It had made our work so easy, and this is a very good experience that we've gathered over time. I must equally say that multi-stakeholders engagement, it can be challenging, but you will improve project outcome with a good collaboration. Now let's come down to the results. This is actually very, very key because this is a result, a one-year result from January to December 2025. You could see both community and facility intervention. We've been able to screen over 1,77,000 individuals. And if you look at number screen in the community, which is over 1 million, and number at the facility, which are about 59,000, because the facility intervention, we actually finished the deployment by late last year. The results are still coming up. We know the number of presumptive, but there are some comparison and some takeaway here. If you look at the number needed to test, the average is 5. That shows that this is very, very highly efficient intervention. Unfortunately, we didn't disaggregate this data by gender. You could see that this is one of the singular intervention in TB program that targets the male, and even the yield are actually very, very encouraging. It could be explained because these services are provided in the communities, most times in the evening when they must have come back from work, and it targets some congregate setups like the prisons, of which you know that more male gender dominate the prisons, and we've seen the result. Another thing very key here, takeaway, if you look at the clinical diagnosed case under the community, these are about 21,000. If you work out the percentage, the community intervention is giving us 75%, 77% clinical diagnosis, but for the facility-based intervention is about 51%. This actually shows we actually saw this data early in our scale-up, and we are wondering, was there any overdiagnosis? But when you look at the community, that most of these cases are picked early, even before they have the telltale sign in the lungs, and interposing it with our quality assurance system in the SMAP, we could actually beat our chest that these are the real results. I think everything is very clear here that the PDS intervention had remained very efficient, and I'm sure now that we've finished the facility deployment, you could see the number coming from the facility moving up, and the XMAP system had equally helped us to have the dashboard and visibility across all the platform. You imagine having 370 platforms across the country, and the click of a button at the dashboard, you will be able to see the activity across all the states and every location that we have this platform deployed. Now, key challenges. Despite these successes, we've actually seen some key challenges. But with the supportive systems we have, with the national program, the state team, and even the global fund, and even the prime under CPPM, the IHVM team, we've been able to address most of these challenges, and the results had actually been very, very phenomenal. There could be issues with logistics or moving of these tools, especially how to reach location, or which the Global Fund had provided resources to support logistics. Weight of equipment to be carried had actually been an issue. Advocacy communication, you must mobilize, you must engage the community before the deployment to ensure acceptance, and it will help to get the people that will be able to come out for needed assessment. And in sometimes we've had missed opportunities where you've been able to profile a presumptive within a community, and there are no adequate linkage for diagnostic follow-up and even treatment initiation. In few of these PDS in the community, we could couple them with TrueNat or TB Lamp, where diagnosis can happen on the spot. And what you now need is linking up with the community team, the CBOs, the TBL supervisor to ensure that they are linked to treatment. But in some instances, you could actually deploy the PDS without a molecular diagnostic component, and you may miss some of these patients presumptive when they are referred for molecular diagnosis. So we had issues with downtime, turnaround time, but with the onboarding of local partners, supporting the equipment manufacturers, we've actually seen significant reduction in turnaround time. Most equipment replacement can happen within 24 hours. And one key challenge had actually been HR. I must tell you, we had issues even addressing the welfare of this radiographer, because they are very high demand in the market. And for you to keep them, you must actually be sure to have a very enticing salary package. And this had actually been an issue. And but luckily, we have them paid with radiography technicians that had helped in filling some of these HR gaps. Now, these are some of the pictures from the field. If we see the awareness on Keke in a market in Anambra State, in a school, and equally for the youth service, we actually domicile this, and they are targeted for active case finding within the communities with very, very significant results. In transporting this, we have had to go to very hard to reach locations across rivers using boats. Sometimes he can equally use the rickshaw Keke to transport the PDS tools. And sometimes our team walk across bridges in very hard to reach locations. Now, I must use this opportunity to acknowledge the teams that made these successes and results possible. The National TB Program, Federal Ministry of Health, I will continue to blow the trumpet. They made our work so seamless, and there's no way we can talk of the results without mentioning how we've been able to work so well with them. And the State TB Program across the 30 states, the facility staff, and the Global Fund that made the massive scale-up, one of the largest in this part of the world, possible. We must commend them. The Institute of Human Virology, they're actually the prime for the HIV-TB grants, and they will leverage from their support and the Global Fund funding through the prime to support the community active case finding, supporting the logistics. And I must equally thank Delft. That pilot DLB is what had made these results possible, because we're able to work with Delft to showcase what we can do with that targeted intervention. The picture you can see here is one of our greatest success stories. The team here made up of 5 team members manning our Northern Wild Truck. All of them wrote abstracts on the work that they do, and all the abstracts were accepted in the last union conference in Denmark. And with support from DEFT and other partners, we were able to get them to Copenhagen, where all of them made their presentation. We must equally recognize the local country partner for DEFT that had worked so well with us, and the experience from that had informed other partners engaging local team players that have built their capacities for stocking of spare parts. And I must not fail to appreciate the TB-affected individuals that benefited from this support. And most importantly, our staff in KNCV across all the states in the country and the country office. Thank you, everyone.
Yeah, thank you so much, Dr. Dume, for that exciting presentation and the insights into what happened in Nigeria. I have, before I open it up to the audience to make comments, provide, give any question, make any questions. We kind of, this one I have to mention that is a very timely presentation for us as a country. We are currently scaling up this intervention of TB screening in the community using more effective means, and specifically AI supported AI supported digital radiography. Of course, we are not where Nigeria is currently, but we hope probably should be there soon. Now, but still, to add on that, there's a very strong drive towards making the government take lead in most of these interventions as the partners provide support, which also comes out very clearly in your presentation that it's not possible to make achievements without deeply engaging the government. Now, I have a few questions, and probably you could, and a few comments. One, and first, you mentioned about wellness on Keke. That one I've seen some. We saw this one sometime back in one of the union conferences, and one of them, one question I wanted to ask is that how have you found working with the two staff on these motorcycles? I mean tricycles that you go to the community. One of them being the driver, at the same time the laboratory person or the radiographer. How has that one worked out? And is that one feasible, or you think it could be something that could be rethought? Secondly, how has been the maintenance of this equipment? I mean, the downtime of this equipment. You know, they are meant, of course, they are meant for the community, but we cannot rule out the fact that, you know, they kind of uh, have the. I mean, when they are not in one place, they can potentially break down, especially given the roads in most of our. I mean, the status of the roads where we do find these people who need to be screened. The hard to reach areas usually don't have the best roads, and most likely they could break down. How has been the downtime, and how you have managed that? Thirdly, who have you trained to do radiography? You realize the radiographers are not a very common cadre. And you know, with this expansion of this technology, you need them. I mean, to match. I mean, the need for their services, and this one sometimes may not match out. So, which cadre have you trained? Do you train clinic officers? Do you train nurses? Do you train? I mean, what kind of people do you provide the training to be able to do the work? And I will leave the others for the others, but I just wanted to ask the last question. What's your comment about the proportion of the bacteriologically confirmed to the clinically diagnosed in your findings? I kind of find the number who are clinically diagnosed beyond what I would expect. But if they are TB patients and probably they have been confirmed by the experts, that is okay. But I still find the proportion a little bit out of range. Over to the rest of the team. By show of hands, please raise up your hand and I can select you to ask or make a comment. Yes, Dr. Aldo, please go ahead.
Yes, thank you so much, Dr. Deus, and thanks so much, Bertrand, for a great presentation. And I think just to add to the moderator that this presentation is indeed timely and is helps us to guide our scale up of digital X-ray. As a program, National TB program, we already have a number of systems that we are targeting to deploy in every district. So we really take a lot of lessons from your large implementation. I have a few observations in addition to what Deus has already raised. Now, one of them is the issue of the card threshold score. I noticed that you have two different thresholds, one of 40 for community screening and 34 for key vulnerable populations. How easy do you find that to implement, given that in operational settings, it's difficult to distinguish who is who until maybe after the X-ray has been done. So is this disaggregation done later after the maybe at the level of reporting or at the time of implementation? That is one. And then my second question is, how were you able to target which communities for community screening? I would be interested to know whether XMAP also was able to do geospatial mapping to be able to identify which populations to target for screening, and how actually this XMAP is able to, I mean, its accuracy in terms of predicting the hotspots and also finding the TB cases there. Then uh, I just want to add to what Dr. Deus raised about the issue of the clinical diagnosed TB. I suppose these were not bacteriologically confirmed. So how did you ensure that these were indeed TB cases who require treatment? we've had challenges in our program, and actually, generally, we discourage diagnosis of PC, clinical diagnosed patients from community screening using chest X-ray. But I noticed that from your presentation, there is a program for quality assurance. I would wish you to explain more how this QA is done to ensure that the people who have suggestive X-ray but are not biologically confirmed, there is a due process to indeed determine that these are indeed TB patients who require treatment. How that was done has been very good to support our implementation. Then lastly, it's to do with the issue of regulation. In Uganda, we have the Atomic Energy Council of Uganda. Probably you have a similar body in Nigeria that regulates operations of radiation emitting devices like chest X-ray. There have been some challenges and concerns raised that these portable X-rays do not come with adequate protective wear. I know that they normally provide the lead apron, and you find the radiographers keep insisting that they require a lead shield in addition to the lead apron to improve on the protection. And even some facilities have been hesitant to use the X-ray systems, saying that they first need the standard X-ray room with adequate protection before it can be used. How we're able to address these concerns, given that you have a large number of units, over 370 deployed in the country, compared to what we have in the country where we have less than 100 units available. Otherwise, I thank you so much for a great presentation, and we look forward to taking more lessons from this. Thank you.
Yeah, thank you, Aldo. First, I thought, do you want to take those? We have about 10 minutes. I don't know whether we should want to
it would be
respond to
nice.
this.
I
Okay,
have
fine.
these questions here so that
fine.
even providing the answers may help other questions that are still not yet asked. The good thing, I have some of my team members, and I will be calling them in for responses as the case may be. But I will start from questions from Deus on the awareness on Keke and how we're able to man the awareness of Keke with 2 staff. I must tell you, as I said earlier, what actually informed this innovation of awareness on Keke is our experience with the awareness on wheel. You've seen that massive truck, and we know how much is paid annually for the maintenance to the manufacturers. A retinue of staff. It has the driver, it has the radiographer, it has the laboratory technician, it has the data clerk, about 4 to 5 staff per wow truck, and you have to fuel. It has a generating state. We've actually looked at the cost and for sustainability for us, and what can actually fit our setting. That's how we come up with the work. And I will tell you that initially, when we started, there was this need to engage a driver. But we looked at the 2-man team, assigned the work, and most of them were very willing to take up that responsibility with the short training and the licensing. And that's what had worked for us across. By that, we've actually reduced the cost. And looking at the 2 staff, these are the 2 key staff. The radiographer is manning the PDS or radiography technician, and the lab technician, lab scientist is manning the molecular diagnostic tool. But what had worked for us, these are the core staff that we actually have in our payroll. But I've said how we've been able to leverage from the Global Fund, because what Global Fund had done, that they have actually certified community-based organizations across the state. These communities are actually the people that ensure the community mobilization. Once a community testing site is identified, they provide other needed support. They support in recording, they support in patient engagement and counseling, and that had actually helped to reduce the cost. I will tell you that for you to implement this, those 2 staff may not be enough because there equally be need for documentation, or which would leverage from the support from the community-based organization engaged under Global Fund. And significantly, we've been able to reduce the cost of its operation. Now, we've talked about the downtime. This awareness, if you're looking at downtime, I may look at it in 2 sides. The downtime of the awareness on Keke when it breaks down, and even the downtime of the tools. Be it TrueNAT, be it the TB lamp, or even the portable digital X-ray. I will tell you that those awareness on Keke, we in our budgeting, you must make provision for routine maintenance, and that's what we've been able to ensure. They were actually procured new, and for the time being, it had not been an issue. But ensuring routine maintenance, this actually the culture we've imbibed. If you notice that we had this awareness on wheels since 2017 until date, they're still very active in the site. And learning from that experience, what actually works is being very proactive in maintenance. And that's how it worked for the awareness on Keke. But for the other tools, be it the PDS, the TrueNAT, or TB lamp, the engagement of the local agents for this manufacturer had been very, very efficient. Because when we notice any of this, unlike before you start reaching for them overseas, they already have stocked of these parts in country that we could call within 24 to 48 hours. We're able to ensure parts replacement or even a repair. Now, the other question you asked is on training of a radiographer, the cadres of training. I think in our training package is actually structured. The people that actually man these PDX are actually the radiographers or radiography technicians. They're equally another kind of trainer you may need. Those that are going to be the data clerk, that are going to collect this data in the field, because there's no way the radiographer or radiography technician will be manning the tools and equally be able to record. And the way structure this training, they actually train together, be it the radiographer or the technician, even the data entry clerk that support actually a modular training. And this actually happened. We have a training of trainers that have already, a pool of trainers at the central team, making up of KNCV, the National TB Program, and some state staff. And during those deployments, these are the people, and they equally work with the local vendors representing these 2 manufacturers to ensure the training. But what we have noticed that it doesn't really end in the training. Awareness creation equally comes with it in facility deployment, because sometimes these 2 may be in the facilities and the clinicians that may need that referral may not be there. That's why those webinars we had at the initial time, of which over time should actually be repeated, is basically to create awareness, because for most clinicians, this is actually a new tool. Most of them had known about fixed X-ray, but coming to know that X-ray can be mobile and with AI is actually a very new thing within the system. And okay, you equally asked about the clinical diagnosis, how high it is. If you look at comparing both the community and the facility base, the percentage for community is almost above 70%. The percentage for facility is about 50%. I agree with you. When we started this intervention, we had noticed this over time. Even working with the USAID, some queries had come, are you not overdiagnosed? But if you look at the basic empirical evidence, in the community, you are moving to the community, you are picking some of these cases very early, even before they have developed the telltale sign of lung scarifications, cavity, and all what have you. But we saw those results, and that's actually what informed the introduction of the quality assurance. They are blinded testing where one radiologist could say that this is suggestive, and he goes to another radiologist for concurrence, even before we can accept the result. And we've instituted quality assurance system over time, and we can actually beat our chest that is this result actually rare cases, but very early cases being picked from the community. And looking at what is coming from facility, very lower, in as much as you may equally see that is high, but everything goes to tell about the AI and the utility in the profiling of these TB cases. And that quality assurance test had actually helped to reassure us that in actual sense, these are actually cases. And note you that these clinical diagnoses are actually made because some people are presumptive, but they can't be able to give you sputum. You can't say that they don't have TB. But I must tell you, even stigma in the community. You could see some of the clients that may be coughing, and knowing that the most known symptom for TB is cough. They tell you they don't have cough. But once you shoot them the X-ray with AI, you will be shocked to see the telltale signs with some of the heat maps, and we're able to profile them using the threshold score. And then some of them are even encouraged to produce sputum. They will, some may not, and the digital X-ray is uploaded through the XMAP for the radiologist to read. I think that answers another question from Ado on quality assurance system. But the quality assurance system, I may link it to your question. We've actually developed it with the local partner over time. I will tell you, my team here, even the MIE, will tell you that is very, very time consuming, because we developed two systems for quality assurance, where in two arms. One radiologist, we profile the results report from a radiologist, those that are confirmed as a presumptive and those that are non-presumptive, and gets other radiologists engaged to equally read same X-ray. They don't know what is actually blinded. They will read it and will be able to compare what is the concordance across all those radiologists, be it non-presumptive and presumptive. But another form of quality assurance test way that we have the X-rays, we equally have the bacteriological results. We now profile confirmed TB cases, be it from GeneXpert, be it TrueNat or TB Lamp, and we know that these are confirmed cases. We traced the digital X-ray films and share it across the radiologists. I equally see their concordance with the bacteriological diagnosis and these results. Now, we have done this thing manually, but what is new now with the XMAP team is that they have been able to automate this process. It's just for us to activate the auto function at any given quarter, and we will be able to generate the result. And I must tell you, this is very, very key, because we've been able to step down one or two radiologists based on the outcome of this quality assurance system. And that's the best we could do to be sure that when we say that this is a clinical diagnosed TB, that's what it is. Now, coming to Ado on the CAD score, the threshold, good thing, it would be nice equally we will be able to share the national program, the normative guidance from the SOPs and the guidelines. I think these things have been developed over time. We started the awareness on whale truck. There was a time the cutoff was 60%, 50%. But I must give the credit to USAID. During the New Tools project, where they funded the additional initial scale-up with 10 PDX, there was inbuilt implementation science research led by USAID. Then we all worked together, looking at the robust data that we have to be able to do recalibration of this threshold. And I must tell you that we have used this over time locally. We've been able to recalibrate, but the evidence is actually what came from the New Tools, of which those publications, you can see it in our site, that informed this categorization, that when we are targeting key vulnerable population. And you asked a question about site selection. I will come to that. We step down, that is formed by evidence, by that 0.34 and 40 for other settings, be it high volume, low volume facilities. But for key vulnerable populations, we've stepped it down, and that's based on evidence. Our team will be able to share the publications from that calibration. And I must tell you, we've seen the utility since that introduction, because definitely with key vulnerable population, when it was 60 or 50, we've been able to miss a whole lot of cases. Now, for a question on site selection, one good thing that I worked on, unfortunately, I didn't show it here, that we have hotspot analytics mapping. In country, there's EWAS, early warning outbreak recognition system, which we piloted, and we are working with National TB Program, and there's EFCON, which other partners are using. This is actually dynamic hotspot. They generate data from your system, from the epidemiological data, and you get a alert system. Every member of our team across the state TB program, have access to that alert. It's actually a dynamic that every week it will give them pinpoints to what sites where there's possible increased number of TB cases coming. And this is actually what informs the deployment for community intervention. Knowing how costly it is for community intervention is not what you just go randomly. It must be informed and it must be targeted. And that's what it was. And it doesn't even end with it was. Our team equal look at our data from the genus part, from what we are reporting, and they can actually target well. And there are some settings that are known to be high burden for TB. That's why I said in that strategic framework, you must do your mapping. Where are the IDP camps? Where are the prisons? Where are the detention camps? These are, you don't even need hospitals to go there. These are the key vulnerable affected population that in every state, we actually made it routine that every 6 months we target the prisons. But for the community intervention, hotspot analytics will equally be key. You talked on the SMAP. SMAP is actually for the clinical diagnosis, linking the radiographers and the radiologists and ensuring timely reports on those results. It has no inbuilt capacity for hotspot analytics, but I agree with you that the robust data in SMAP can actually feed into any of the hotspot analytics to ensure targeted active case finding. But currently, it's either EWAS or EPCON that the country is using. I've talked on increasing clinical diagnosis and the introduction of quality assurance system. For regulation is nuclear regulatory authorities. I don't know, the project coordinator, Dr. Eze, if you can talk more on this, because we had extensive engagement and the approval has been very, very key, even in the initial deployment. And not only they have gone from state to state, checking the best practices in this deployment. And you've talked about protective wears. It's actually mandatory that every radiologist will have an apron, and we have equally a device that they use to monitor the load of exposure, and we keep track of exposure across all the radiographers within our system. But I don't know whether Dr. Eze is here or any of the radiographers at the center to talk more on this nuclear energy regulation. Dr. Eze, are you here? Mary, I'm sure they're in the field, but if you need further information on this, we will be able to provide to the team. But if any of the team members is here, they can equally shed more light.
Okay, thank you. I think we can also get that on. We are with the number of I can say a hand still up, and we kind of overshot our time, and of course we must have some word from Professor Bruce. At the end, I would request Damali to go ahead with your question. I think let us give it another 3 to 4 minutes before we can close. Thank you so much for the responses. Damali?
Thank you, Dr. Lukoye. A very, very quick question indeed. Just wondering about the experience with children. The data provided is not disaggregated, so it's not easy to tell if children are utilizing this service and if it's helping with diagnosis of TB in children, and also if it's being utilized beyond just diagnosis of TB to follow up, identifying patients with post-TB lung disease and the like. If you could respond to those very quickly. Thank you. Over.
Yeah, and there's one in the chat that how does the yield from AI-powered diagnostic compare with the empirical burden of TB disease? And how does AI-powered diagnosis compare with the genotypic molecular diagnostics and the golden standard? And lastly, from me, is there a value of administering both symptom screening and the digital X-ray screening with AI at the same time, knowing that X-ray is much more sensitive than the symptom? So what's the added value from your results? Over.
Okay, yeah. Let me come to the children, and I will be happy to that if the dev team are here, because as if you are reading our mind, there is actually an ongoing collaboration with devs to look at the utility of the PDS with AI in the children. I must tell you, this is a group that we needed to do more, considering the gap in pediatric case finding in the country. But some of the drawback we had is there's actually age cutoff for the use of these PDX in children, and that had been a very key limitation limiting factor. But unfortunately, we were not able to disaggregate. We have those data, but I think in further engagement in some of our public, we will look at the contribution to pediatric case finding, which we actually have. But I must tell you that looking at the age cutoff, because we below the age of 6 or so, we hardly have the children exposed to AI. But I think new evidence is actually showing that they could be safe in a pediatric age group. And we have a targeted intervention with DEF that we are looking from the operational research angle. I agree with you that this is another area that needs us to do more. Now, for the yield of this AI compared to genotypic monitoring, I wish our lab folks are here to talk more, but I must tell you that looking at our data, the yield from AI assisted X-ray had surpassed any of our intervention. We've seen it both in the bacteriological, you've seen the number needed to test and number needed to screen. And this is actually very outstanding looking at the result we've garnered thus far. And they had actually shown some efficiency because you profile the rare presumptive that could go for molecular testing. And there have been recorded cost savings even in the reagents and cartridges for GeneXpert across the country, even the reagents for TB lab. And looking at the comparison, I think these are probably another area for research for the true cases, maybe the clinicals, but for clinical diagnosis case, getting even the samples for further molecular testing had been a challenge because most of them could not be able to produce sputum. But looking at the threshold, you could see that it merited a categorization as a presumptive clearance. Now, the last question on the value of both the WHO symptom screening as well as the X-ray. I think if you look at our experience and the published work and the guidance and the algorithm adopted by the country, we looked at a different setting in key vulnerable population, which we have the map where I can tell you in any given state the settings that fall within this group, high volume facilities, low volume facilities, and the community. You could see that the lowest margin of that threshold is for the key vulnerable population. Now, parallel algorithm are actually what we've adopted in population setting, especially in high volume facilities and the key vulnerable, to just be able to have a watertight system to ensure that there are no mixed opportunities. If WHO symptom screening, I've told you about stigma, where you could actually ask people that have TB that are coughing, they will tell you, no, I'm not coughing. But the result you will see on administering the X-ray with AI will shock you. I've had instances, and there if actually documented, that people that claim that they don't have cough, on passing through the digital X-ray with AI, seeing the cavities, the mapping there, they are encouraged, and some of them own up when they see the films and give you sputum that turns out to be a clinical bacteriological diagnosis case. And in such settings where we see the need, not because you know that they're high burden, that parallel algorithm had actually been applied. And we will equally be able to share the national tool, the guideline. You could see the categorization, how we'll be able to adapt those algorithms for each given setting. And that has been very, very phenomenal. But in low burden, in high burden facilities, looking at the timing and everything, they actually informed some decisions in having those tray-given algorithm, which you will see in the guidance document for PDS implementation. Over. I don't know any member of my team. Yeah, if you guys can allow any member, it would be nice to have them speak. I know that they're in the field. Dr. Eze, Dr. Sheshi, Mary, Nkiru, it's been a very good teamwork, and I must commend them for the result we've been able to demonstrate. I don't know any of them is here to make one or few comments. Okay, everybody is in the field, and I had to stay back for this. And equally, zonal meeting is ongoing.
Yeah, thank you.
Over.
Thank you so much, Dr. Dume. This has been very, very fruitful, I think, and very timely. Like I said earlier, there are several questions actually which keep coming through, and I think we have to remain in touch. And I think at an opportune moment later during the course of our implementation, we shall call you up again and share with us more experiences. Yeah. At this point in time, I would call upon Dr. Bruce Kirenga to give the final remarks before we can and also close the webinar. Thank you so much. Over to Dr. Bruce.
Sorry, unfortunately, I think we lost him, but we have Dr. Winters online. He can share the closing remarks.
Okay, Dr. Winters, please.
Okay, yeah, you ambushed me a bit, but allow me thank Dr. Dume for this very enriching and very fantastic presentation. So many lessons to pick as a country. And for those who worked with the Lung Institute, one of the things we keep advocating for these south-to-south collaborations or engagements, because then we get to learn many things that we could use to support and improve our health systems, and this is just one of them. I also want to thank the attendees. This has been well attended. We don't take this for granted. I hope it's been enriching as it's been for all of us. And I hope there will be follow-on discussions and engagements to see how we pick up on some of these. I'm happy that the NTLP for Uganda is heavily engaged and involved and has attended. So we'll definitely keep in touch with you, Dr. Dume. Probably maybe one day you might even make the trip down here to support some of the initiatives that we are currently undertaking. And then for all of us, just to let you know, this is one of our premier programs, the Day of Lung Science at the Lung Institute, that happens once a month, where we discuss topical issues. If you did register, we should surely be reaching out to you with more communication on what the topic will be for our next engagement in February and how you can join. I know some of you have very important findings you might want to share. So we'll definitely be able to reach out to you. This webinar has been recorded. It will be shared on all our social media platforms, but largely YouTube, just in case you want to share with the people who might have missed, or even use it as a reference, even as we go about our work. Having said that, allow me thank you, everyone, and wish you a fruitful remainder of the day and the entire week. I now close the webinar.
Thank you, everyone, for your time.